Today our program is to provide information about ovarian cancer for healthcare providers here in Texas. Ovarian cancer is the 5th most common cancer affecting women in the United States and the 4th most common cause of cancer death. Unfortunately, ovarian cancer is an illness for which there is currently no screening test and commonly an illness which is found when it is advanced. We have several objectives to obtain today in this video, including discussing the signs and symptoms of ovarian cancer along with new guidelines, discussing the incidence and prevalence of ovarian cancer, defining the prevention and treatment options, including surgery and chemotherapy, discussing survivorship and resources for healthcare professionals, and we have some stories presented by survivors of ovarian cancer. When talking about the signs and symptoms of ovarian cancer, it's very important, as usual, to go back to basics. We need to talk with our patients. We need to know why they're here to see us today and what are they suffering from, what are their symptoms. We need to know if they've ever had cancer or who in their family has had cancer and what type of cancer. This is particularly important in ovarian cancer, as 5 to 10% of ovarian cancers are genetic or familial. Particularly, you want to pay attention to other women in the family who've had ovarian cancer or breast cancer, particularly if it's premenopausal. We want to conduct a complete and thorough history and physical exam. In particular with ovarian cancer, these are some of the symptoms that we need to pay attention to. We need to ask patients if they've had these symptoms in the past year. If so, how severe, how often, and how long do they last? Ovarian cancer can cause pain, particularly pelvic, abdominal, or back pain. It can cause difficulty eating, leading to symptoms of indigestion, unable to eat normally, nausea or vomiting, or weight loss. Women will often complain of abdominal bloating, their pants or skirts feeling tight around the abdomen, an increase in the abdominal size, or occasionally they'll complain of being able to feel an abdominal mass. Other symptoms that women with ovarian cancer may complain of are bladder symptoms such as urinary frequency or urgency. This can be caused by the pressure of a pelvic mass on the bladder. They also may complain of constipation or diarrhea, changes in the bowel habits, again that can be caused by pressure from a pelvic mass on the large intestine. If they're premenopausal, they may complain of menstrual irregularities, or if they're postmenopausal, may have postmenopausal bleeding. Women may also have difficulty with intercourse. They may complain of pain during intercourse or bleeding with intercourse. A common symptom is fatigue, and although it's nonspecific, it's one of the most common symptoms of ovarian cancer. Women may also complain of leg swelling or other symptoms, or they may have no symptoms at all, and a mass is found incidentally when a pelvic exam is done. Some of the clinical features that we see with women with ovarian cancer include abdominal distension, ascites, or bowel obstruction. This picture shows a woman with abdominal distension that is caused by ascites or accumulation of fluid in her abdomen from the cancer. Occasionally, women present with their ovarian cancer with a bowel obstruction, complaining of no bowel movements or flatus and nausea and vomiting. If a woman presents to you with signs and symptoms of bowel obstruction, this is a life-threatening condition and she needs immediate care. You should direct her to go directly to the hospital for possible surgical intervention. This slide depicts a malignant ovarian tumor. In this slide, we see a woman's abdomen open. We see the uterus in the middle of the slide and the ovarian tumor in the surgeon's hand. The tumor is about 3 times the size of the uterus. If you look at the contour of the tumor, we can see that it is somewhat irregular and granular. This makes us very suspicious that it may be malignant, and indeed, this did turn out to be a malignant epithelial ovarian tumor. As you can see, the symptoms of ovarian cancer are quite nonspecific and they're very common. Most women, most men, most everyone has had these symptoms at one time in their life. The important thing to recognize about the symptoms of ovarian cancer is that they're of recent onset and they happen frequently. Most papers suggest that they happen more than 8 times a month and have lasted more than 3 weeks. The treatment for ovarian cancer generally starts with surgical cytoreduction. The importance of this surgical cytoreduction is to decrease the amount of tumor that a woman has left behind. If each tumor is 1 centimeter or less left behind after surgery, the survival of the woman improves. Studies have shown that if a gynecologic oncologist performs this surgery, they're much more likely to leave a woman with an optimal cytoreduction and therefore improve survival, compared to a regular gynecologist or a general surgeon. This just reiterates the importance early on of involvement of a gynecologic oncologist when you see a woman who you suspect may have ovarian cancer. This slide shows the leading sites of estimated new cancer cases and deaths for 2009 provided by the American Cancer Society. As you can see, ovarian cancer follows behind breast, lung, colorectal, and pancreatic cancer in incidence and causes more deaths than the other gynecologic cancers combined. Although endometrial cancer or corpus cancer is twice as common as ovarian cancer, far more women die from ovarian cancer, mainly because it's a disease that is found at most times when it's advanced staged and more difficult to cure. This slide shows all of the gynecologic cancers estimated for 2009, and as you can see, there are about 80,000 new cases of gynecologic cancers per year in the U.S., and around 25 to 30,000 deaths. Ovarian cancer is the second most common type of gynecologic cancer, but the most lethal. It's responsible for more deaths than all of the other gynecologic cancers combined. This is due to the fact that there is no screening test for ovarian cancer, and there are currently no ways to detect it early. Although there are symptoms of ovarian cancer, which you'll hear about in this video, the symptoms are very vague and nonspecific, and it is difficult to find it when it is early. And 75% of women with ovarian cancer are found when their cancer is at advanced stage and much more difficult to cure. Uterine cancer, although it has no screening test, is often found early because postmenopausal bleeding is often an early warning sign of early stage disease. And cervical cancer, we do have a good screening test for, the Pap smear, and since its inception over 50 years ago, the incidence of cervical cancer has been on a steady decline in the United States. Although there are no screening tests for vulvar or vaginal cancer, these cancers are much less common and account for only a small proportion of deaths from gynecologic cancers. The lifetime risk of a woman developing ovarian cancer in the United States is about 1 in 70. If we compare this to the lifetime risk of breast cancer, which is 1 in 9, it's much less common. However, the chances of a woman surviving breast cancer is much greater than ovarian cancer. If we look at the 5-year survival rates by year of diagnosis for women with ovarian cancer, we can see that over the past 20 years, women are more likely to survive at least 5 years with their ovarian cancer. However, if we look at the mortality over this period of time, it is relatively unchanged. We have developed newer treatments that are helping women with advanced ovarian cancer live longer, but many of them are still dying of their disease. This goes back to the fact that many of them are found still today when their cancer is advanced.
My name is Trish, and in the summer of 2006, I was diagnosed with stage 1 ovarian cancer. At the time, I was a 35-year-old mother of 2 with no family history of breast or ovarian cancer. In January of 2006, I went to visit my gynecologist for my annual exam, which I did every year, and I explained to her that I was having some stress incontinence and some irregular periods, but nothing else out of the ordinary. After my exam, she had suggested that I go get a baseline mammogram, and while I was there, I could go ahead and get a pelvic ultrasound as well to rule out some uterine fibroids, which may or may not be causing the symptoms that I had talked to her about. So she gave me all of the paperwork, and I took all the paperwork, and then I went home and put it all in my desk drawer. Between January and July, from when I was diagnosed, life got in the way. I was distracted by work and family and other dental issues that I really felt that I couldn't take any more time off work to go get these tests done. In May of 2006, I started to experience some more symptoms. I was easily tired, I had a lot of fatigue, I had frequent indigestion, gas and bloating, and I was beginning to gain weight and around my middle section, which is not normally where I would gain weight. But my friends and family had noticed that I didn't really look myself, and one of my friends had suggested that, if I hadn't already gone for those tests that my doctor had ordered in January, that maybe I should go. So that's exactly what I did. I scheduled the mammogram and the pelvic ultrasound. I did that in mid-July. After I completed those tests, before I even got home, my doctor had called and left a message saying that I should go in. She wanted me to come in and get paperwork for a CA-125 blood test and an MRI, which I did. I went and took the blood test. I had the MRI. The day after I had both of those tests done, my doctor called me and asked me to come into the office. I went into the office and she explained that my CA-125 was in the mid-50s, which was elevated, and the MRI showed that I had a growth on my left ovary, and she wanted to refer me to a gynecologic oncologist. After my exam with him, he had thought that he didn't really think I had ovarian cancer. He thought something was going on, that my ovary needed to be removed, but he was pretty confident that ovarian cancer was not the issue. We scheduled the surgery for mid-August. The plan was to remove my left ovary, leave everything else. When I woke up from my surgery, I was told that I did in fact have ovarian cancer. It had spread from my left ovary to my right, and that I had undergone a complete hysterectomy. While I was in the hospital, we were waiting for the pathology to come back on the tumor, and it was stage 1B, grade 1 papillary serous ovarian cancer, which was estrogen receptive. But my lymph node biopsies were negative, so that put me in a very good position, and my doctor had concluded that really no further treatment outside of the hysterectomy was going to be necessary. I didn't have to have any chemotherapy, and we were just going to follow my symptoms very carefully over the next 5 years, every 3 months for the first year and then every 6 months. I did have BRCA which was negative, and to be honest, where that should have made me feel better, it really didn't make me feel better, because I still worry. There was no rhyme nor reason to why I was diagnosed with ovarian cancer at such an early age, especially without having any family history. And while I worry about that, I also am concerned that I don't bother my doctors. Like, if I have a stomach ache, I don't want to automatically feel like I have to call my doctor because, oh my gosh, the cancer could be back. And so I walk this line of, when should I call? Should I not call? Should I wait until my next appointment? Should I call my oncologist? Should I call my regular doctor? Who should be taking care of me, or should I just let it wait for it to go by? So one thing that maybe I would suggest to physicians, and none of my doctors have ever made me feel silly for calling and complaining about a pain I had. But in the back of my head, I'm always worried that I'm taking up their time with something that might be nothing. So, if doctors and nurses can really reinforce to their patients, cancer survivors, that it's okay to call and that you will be the one to determine whether it's serious or not serious, that would probably take a lot of pressure off of the patient, because I know it seems silly, but it's something I struggle with all the time. Since my initial diagnosis, I have experienced things that I never thought I would experience this early, one of them being menopause. Because my tumor was estrogen receptive, I have not been able to do any hormone therapy, so I went in completely cold turkey, which has not been a very pleasant experience. I've become a Google junkie. I'm constantly Googling whatever symptom I have. If I have a stomach ache or a backache or a headache, I put, backache and ovarian cancer in the Google search engine, because I want to see what could possibly be wrong. And nothing ever is really wrong. I will never just have a stomach ache again. I will always be concerned that it could be something more serious. I've definitely learned to be very grateful for things that I have, to not take work so seriously, to take family more seriously, and to make sure that if my doctor makes the effort to have me go for testing, that it's not just a paper exercise and it's something that I really need to go get done in a timely manner. But at the end of the day, I feel very fortunate that I was diagnosed at such an early stage and that I'm really not going to have any serious lingering effects.
In ovarian cancer, what we look at rather is risk reduction. We look at changes in lifestyle factors, and we look at ways to use some methods for chemo prevention as well as surgical options. Eating a diet that is low in fat and increasing your exercise can help. Having a healthy weight and maintaining a healthy BMI can help. We also know, and there's some research to support, that pregnancy and breastfeeding can help. We know that suppressing ovulation that occurs with pregnancy and breastfeeding can help with the risk reduction for ovarian cancer, and particularly for women who have had pregnancy before the age of 25. Add to that the use of oral contraceptive pills for more than 5 years, we also know that that can help. Chemoprevention includes not only the oral contraceptive pills, but also limiting clomiphene citrate and also possibly limiting hormone replacement therapy. Surgical prevention or surgical risk reduction for women can include having an oophorectomy. We know that particularly for women who have a BRCA mutation, it can actually reduce their risk up to 80%. Having a bilateral tubal ligation, including with that also the use of oral contraceptive pills, can also reduce a risk up to 72% for women with ovarian cancer. I just would like to take this opportunity to also reemphasize the value of chemoprevention. We do know that there's a 50% risk reduction for ovarian cancer in women who have used oral contraceptive pills, and this is a recommendation by the NCCN panel. Prophylactic surgery should be considered for women between the ages of 35 and 40 who have a BRCA mutation or after childbearing ages. This is yet another way for them to reduce their risk for ovarian cancer. Prior to having a prophylactic oophorectomy, women should, of course, be given some pre-surgical counseling. We know that there are some benefits associated with having the prophylactic surgery. There is the prevention or the risk reduction for ovarian cancer. There is also a decrease in a risk for breast cancer by up to 50%. There are also risks that are associated with having the prophylactic surgery. These include having premature surgical menopause, and there is a continued risk for peritoneal cancer even after having a bilateral oophorectomy, and the possibility of finding an occult malignancy during the surgery itself. Any patient who is suspected to have ovarian cancer needs to be referred to a gynecologic oncologist for surgery. We know that patients who are treated by a gynecologic oncologist do have better outcomes, and this has been supported through research. The first-line therapy or standard treatment for ovarian cancer is to have surgery and to have a cytoreductive debulking surgery. This is performed in order to reduce the amount of tumor burden that the woman has in order to then allow her to receive standard treatment with chemotherapy to include a platinum-based drug with a taxane. A cytoreductive surgery is very important in a woman with ovarian cancer. The reason it's so important is because of the unique pattern of spread for ovarian cancer and also because of the growth factor pathways that we see. We also know that there is a decreased development of tumor resistance if we are able to remove as much of the tumor as possible for the ovarian cancer patients. Treatment for ovarian cancer patients can be divided into patients with early stage ovarian cancer and those with advanced stage ovarian cancer. Surgery is curative in 90% of patients with stage 1A or 1B. For patients with stage 1C, we know that they usually have to have chemotherapy following surgery, and this can improve their survival over surgery up to 70%. For patients with advanced stage ovarian cancer, anything over stage 1C, cytoductive resurgery or debulking procedure is required combined with chemotherapy. We know that they will need to receive chemotherapy intravenously or through what we now use as an intraperitoneal port. The chemotherapy that they will receive is, as I said earlier, a platinum-based drug as well as a taxane drug.
My name is Rebecca Esparza, and I'm 38 years old, and I live in Corpus Christi, Texas, and I'm a two-time cancer survivor. It was a particularly stressful time in my life. It was the summer of 2001, and I thought that I was tired all the time. I had a distended stomach even though I was working out at the time. So one evening at around midnight, I woke up with shooting, stabbing pains on my side. And I just couldn't stand the pain anymore, so I went to the doctor. I went to the ER, actually. I spent 8 hours in the ER before I finally got seen, and they did some really rudimentary tests, like basic tests, and they said everything came back fine and normal. If I wanted an ultrasound, it would be another 4 hours to wait. So after being there all night, it was 8 o'clock in the morning, and I thought, I can't be here anymore, so I just went home, and they sent me with pain medication, follow up with your doctor. So I wasn't going to follow up with the doctor, but then 3 or 4 weeks later, I thought, this isn't going away. I still feel funny. And so I went to go see my gynecologist who had done my previous surgery to remove fibroid tumors. He said, I saw you in April and you looked fine. I didn't notice anything. And now here it is September and it looks like you're 3 months pregnant. I'm very concerned. I can't know for sure what's going on without doing the surgery, but it's certain I see at least 15 fibroid tumors. I went in thinking that it was just going to be routine surgery to remove fibroid tumors, and when I woke up, I had my parents weeping uncontrollably at the foot of my bed. I'll never forget, and I just remember waking up and looking at them and thinking, oh my God. Oh my God, why are they holding each other up and why are they crying uncontrollably? And I just thought, I'm just going to go back to sleep. I can't handle this right now. I don't want to know what's going on. At first I found out that they had to do a radical hysterectomy, and then they told me, yes, it was cancer. And then they said we wouldn't know what type of cancer and what type of treatment I was going to have for a couple of weeks. And I remember this social worker walked in and she looked at me like I was already dead. She looked at me and she said, you're going to have to apply for Social Security disability because now you won't be able to work. And, you have to talk to your family members about what you want, about what type, do you want to be on a respirator? You have to have a living will. And I remember thinking, what is she talking about? I could see the fear in her eyes, the way she was talking to me. And she freaked me out more than anybody during that hospital stay. So I went back to Corpus to go recuperate from the surgery, and I had to find out over the phone that I was going to have chemo. I was bawling, crying from the thought of losing my hair. And then once I lost my hair, I realized that's the least of my worries. The hair is the least of my worries. That is way down on the list of priorities, I learned. But when I initially found out, that was the thing that really, really devastated me because it was way beyond my shoulders at the time. So the only choice to me at that time was indigent care. One of the huge worries for me was the fact that it was county care and it wasn't going to be up to par. And, there's all these cancer centers that I could be going to, but I would have had to have moved to that city, and I could not afford it. I couldn't even afford the treatment. How am I going to afford to stay somewhere for weeks and weeks on end? And I had some people tell me, oh, snicker, that I was going to get less care than desired, or less care than other places. And that couldn't have been furthest from the truth. That could not have been furthest from the truth. They saved my life, and it was the finest care. With my second cancer, I was particularly devastated because I thought I was in the free and clear from cancer again. 5 years of being in remission from ovarian cancer, and then I find out I have a second cancer. You could have knocked me over with a Mack truck. I literally thought my world was crashing in from under me. Literally. And the doctor that had to break the news to me couldn't have been sweeter and nicer. And he spent like an hour with me, and I know he had a waiting room full of patients to see, but it didn't matter to him. He was going to help me get through that, and he wasn't going to leave that office until I was okay. And I was shuddering there crying in his office when he told me, and he just grabbed my hand and he said, "You're going to be okay. I'm going to take care of you." And it was just that extra little caring bit from him that really brought me through. And I thought, okay, well, if he says he's going to take care of me, then I'm going to put all my faith and hope in him and in God, and know that things are going to be okay. So he gave me what I needed to pull through it, along with my family and my friends, and God, of course, to get me through that second cancer diagnosis and the subsequent surgery. I didn't ever think I was going to have another surgery, another cancer surgery, and it was, I just can't describe it. It's still emotional for me to talk about. It's like cancer's chasing me. I feel like cancer's chasing me, and I'm running as fast as I can. I eluded it for 5 years after my ovarian, but it caught up with me. And right now I have reactive lymph nodes in my neck that the doctors are monitoring, and I'm still being monitored with blood work every 3 months and scans every 6 months. That the doctors are afraid that those reactive lymph nodes are going to turn into cancer again. So it's looming. It's always a black cloud over my head, but I'm trying not to let it take over my life. And I'm trying to do the best that I can to put it in its place, put it in a little box on a shelf, and just let it sit there. And when I need to grab it and get it out, I will. But for the most part, I'm just trying to live my life and live the fullest. And if there's something that I've always wanted to do and I have the chance to do it, I'm going to do it. I'm not going to wait anymore and think, oh, well, I have plenty of time to do that, because that's what I did when I thought I had plenty of time to have children. And now I will never experience that. The closest thing that I'll have to having my own child is my 6-year-old nephew that my sister but graciously loans me. Periodically, she loans me her child, and I'm very, very blessed to have that type of support. She knows how much he means to me, and she basically lets me be a part-time mom to him, which is one of the greatest gifts I've ever had. Well, I guess it's kind of weeded out the unnecessary things in my life. Not to say that any friends were unnecessary or unneeded, but I really found out who was really there for the long haul. And I did have several friends that were scared away by it, and have not been as close since my first cancer diagnosis. But my family has brought us all together more. We were already close, but it made us even more close. And as far as my relationship with my boyfriend at the time, and he's my fiance now, it's brought us even more closer, and it's made us realize that life is so precious and we can't waste time worrying about the small stuff, and we just need to live for the moment and enjoy our lives.
Survivorship starts from the point of diagnosis and continues all the way through until the end of one's life. And it includes not only the cancer patient themselves, but their family and their caregivers. During survivorship, we want to look for ways to make sure that we increase and maintain the patient's quality of life. One of the first areas we want to focus on is managing the symptoms that are related to their disease and to the treatment modalities. Looking at GI symptoms they might be experiencing, such as nausea and vomiting, that can continue well beyond their treatment phase, are important. We also want to make sure that we ask patients about neuropathy issues, neuropathy in their hands and their feet. There are ways that we might be able to manage those neuropathies, and we need to help patients understand that it's important that they communicate those issues and concerns with their healthcare providers. Fatigue is something that we hear about a lot from patients. That seems to be one of the biggest complaints and one of the biggest issues and challenges for patients to manage. Pain is also one of the issues that we need to really challenge patients to consider and not be afraid to talk with us about as healthcare providers. We could go on and spend a whole lecture, a whole period of time talking about these symptoms, but I would encourage you to really focus and talk with your patients about fatigue and pain. As healthcare providers, we can become very focused on the treatment and symptom issues that our patients might bring into their visits with us. But during the period of survivorship, it's important that we remember and address the coping issues and psychosocial concerns that patients might have. Emotional and spiritual distress and loss of control, particularly as our patients really begin the period of transition from treatment into survivorship, are some of the times where we need to help them begin to look at ways in which they can reconnect with family and reconnect with different aspects of their life. Financial concerns and social dysfunction can also be important issues for them. Body image and sexuality are areas for which, as healthcare providers, we ourselves may not be very comfortable talking with them about, but I really challenge you to find ways in which you might open up these conversations with patients and with their significant others. As healthcare providers, we would like to hope that all of our patients would have good outcomes from their treatments, but we also know that is not always the case. It's important that we open dialogue with our patients at the point of diagnosis even about end-of-life decisions and what their ideas and plans might be with regard to death and dying. These emotional and practical concerns are just as important to manage as the physical and symptomatic issues that they experience during the period of survivorship. In addition to the American Cancer Society and the National Cancer Institute, there are some specific resources for professionals and ovarian cancer survivors. The National Ovarian Cancer Coalition and the Ovarian Cancer National Alliance provide some very good literature and information specifically for ovarian cancer patients and their families. The Society of Gynecologic Oncologists and the Society of Gynecologic Nurse Oncologists provide literature not only for professionals taking care of ovarian cancer patients, but also have some resources at their websites for ovarian cancer survivors. We encourage you to go to these websites to learn more about taking care of ovarian cancer patients.